Okay, we're on page 120 in the textbook and 86 in the ring binder. Very first yellow box, restore what was lost. People don't want to be dependent on others. Do you look forward to somebody having to feed you, bathe you, toilet you? None of us want that. We don't want that. In fact, if you ask most individuals, you know, if you could plan your death, what would it look like? And most individuals would say, I would like to have independent living as long as possible. And when I lose it, I just want to go to sleep and not wake up. No pain, no suffering. I don't want to have to rely on someone else to take care of me. So over the past few years, restorative care and transitional care has become a huge medical, financial moneymaker. And what they've done is Medicare has incorporated what's called a 100-day stay. So when you go to the hospital, and let's say you were a diabetic and you got your leg amputated because of your diabetic circulation, medically you can be out of the acute care hospital really within a few days. Once we're sure the wound isn't infected, there's no bleeding or complications, we want you out. But you're not ready, likely, to go home. Your prosthetic, if you're getting one, is probably not made yet. And it's probably not made yet because you still have swelling on the stump. We don't want to make something that doesn't fit. You haven't been taught how to have a new sense of balance when you have lost an extremity. So you're sent to restorative care or transitional care for up to 100 days for occupational therapy, physical therapy, speech therapy, whatever is involved, to get you back to independent living. So we're going to take the tour tomorrow and we'll show you what's called the Blue Hall, and the Blue Hall is restorative care. So those individuals on the Blue Hall, the goal is to get them home. We're going to teach you how to work with your prosthetic, we're going to teach you how to use a walker, we're going to get a ramp built at your house for your wheelchair, whatever those things look like, but we want you to go home. If for some reason you are not ready to go home at the 100-day stay, you have two options. You pay for your stay out of pocket, or you go to the long-term care site. That's it. We had a lady who fell and broke her arm. It was her right arm. She broke this upper bone called the humerus, required surgery for a rod. She was right-handed, so everything she did was based on that. And they were trying to work with her in restorative care. Well, she was a very large lady, quite obese. So her mobility was limited, and to be quite honest with you, the staff was somewhat frustrated trying to do therapy and rehab when she was so morbidly obese. And they tried and tried and tried and tried, and she just wasn't there yet. And at 100 days, 101 days, they put her in the long-term care site. And she died on that site. And the only reason she was ever admitted was for a broken arm. Now that's not the intent of restorative care. We don't need those things happening, but we're trying to get them back to independent living. There is an abbreviation that I want you guys to know. It's called ADL. That stands for Activities of Daily Living. And activities of daily living are the functions that you must be capable of for me to get you out of restorative transitional care and get you home. So you must be able, yes?
What if someone was like in their 80s and they just didn't want to stay? Are they forced to stay if they don't have a family member?
Are they forced to stay at restorative care?
And no, for long-term care, like if past the 100 days.
If there is nobody to take over their responsibility for care into a family setting, they don't have a choice.
So they'll say like you're a harm to yourself if no one's
Right,
gonna take
you are a
care.
risk, there's no place for you to go safely, social workers get involved, mental health gets involved, and they make the decision for you. It is, we said a little bit about it I think on day 2, but it kind of takes us back to that DNR, do not resuscitate advanced directive. I'm telling you guys, if you get anywhere close to thinking about that with parents or grandparents, have them put down what they want in writing, because you want to honor that and not put yourself in a situation where the government or social workers making the decision. I mean, my mom's got a beautiful document in writing and every box is checked of what she wants and what she doesn't want. And it might be hard for us, but I'm going to honor that, you know, if I'm still living when she needs that. Yeah, Melanie?
Like you said, she died, but she went in with a broken arm. So why does it they end up dying because they don't take care of them?
It is. In her case, with being morbidly obese, we had a group of CNAs that were not very nice and told her they couldn't get her up because she was too heavy. So she spent more time in bed. The more time she spent in bed, the more she began to develop contractures, which is where you start getting stiffening and drawing of your extremities. She ended up getting skin breakdown. She emotionally was very depressed and actually quit eating because she would say to you, if I don't eat, I'll lose weight and then I'll be able to get out of bed. It was tragic. It was just incredibly tragic. So a combination of losing weight, limited mobility, bed sores, urinary tract infections, it just spiraled and then she ended up dying.
But I mean, like, the people that don't have a weight problem, they still end up like dying from
They
being
do.
them.
And I think it's a combination of things. I think first emotionally, it's gotta be defeating. Because her problem wasn't her mind. Her problem was an extremity. So you can imagine being told, you're going to the nursing home and we just don't know we have any good options for you. I'm telling you, I'm not gonna be very happy and I'm liable to give up. And I think a lot of people do that. They just say, I'm gonna give up. This isn't worth it. And so the combination of the emotional and the physical, they'll just spiral. Probably some of you know of someone that was put in a nursing home and you hear, they were only there a month and they died. You know, and it's, again, they probably had no will to die.
My grandfather had dementia. I took care of him for 2 years and eventually got to the point where he couldn't eat, so we put him in the nursing home. My family was like really involved, so my family was constantly visiting him and making sure he was okay. But they finally opened up his living will because he couldn't eat anymore and they found out, like he said, he didn't want to feed him too.
Yes.
So he just passed in a few days.
Right, because then you honor that, and you can't swallow, so you have dehydration, malnutrition. You've written you don't want a feeding tube, and you honor that. Now, what do you do on the flip side of that? You typically give them a lot of pain medications and sedation, and so that they are not suffering, because that was their choice. And that's probably what they did with him as well. So, but we want to get them back to their own independent ADLs, activities of daily living. So we want them to be able to be involved in feeding, toileting, dressing, some mobility. They're listed for you on page 120 in the textbook. They need to be able to transfer from their bed to wheelchair, even if they're in a wheelchair. So those things they have to be able to do. And so those become the benchmarks or the goals to get them back home. Even getting them back home, they might have long-term care insurance. My mom, fortunately, my dad was smart enough to get long-term care insurance years ago. And so when she lost the ability to do 2 of 5 ADLs, which is usually the policy's requirement, then you can have somebody come in and assist them with their ADLs so that they don't end up having to go to the nursing home. But again, that requires pre-planning to have a care plan, to have insurance or money, one of the two, and to have a means of doing that. So we're going to try to get them home. Now, getting them home doesn't mean that they won't be using an assisted device. An assisted device is things like a cane, a walker, a wheelchair, a prosthetic. They may be using those pieces of equipment, and that's fine. So we'll go through them. I'm going to do them in the order they are in your book, starting on 121. And the first one is called a prosthesis. This word has been on the test before, and a prosthesis is an artificial limb. So, yes?
Aren't like
Prosthesis?
Even like eyeballs, can they see through
Ah.
the fake one?
No. We have a client, actually, we have 2 clients with prosthetic eyes, and they're basically formed out of a glass porcelain, so they have no visual acuity, but what they're doing is trying to keep the eye socket from sinking in, they're trying to keep down the bacteria from potentially getting in a port of entry.
Is it
And so
heavier than a real eyeball?
it's about the same. It's about the same. We have a gentleman with a prosthetic nose, too, that we glue his nose on every morning.
You
Fascinating.
glue his nose on it?
Yeah, he had cancer, and they had to, take out a real big chunk of his nose and face. So he has this gorgeous nose, and we put adhesive on and put it on him every morning. But that's part of, again, restoring what he felt was lost. Yes?
Is it true that if you're like a organ donor that you can donate your eyes to?
Yes.
And they like, how does that?
And those do work. There are, but we're fine on time, so you guys don't panic if we get sidetracked a little. There are organs that must be donated while your blood is still circulating, like heart, liver, kidneys, a lot of things you hear about with organ donation. There are organs you can donate once you are deceased. Skin, eyes, some bone or bone marrow. So as long as they have that on their order, they'll make the plan to remove those within a certain period of time after death, and they can do transplants. They sure can. So that is one of the, yes, ma'am.
I know this is probably like kind of a crazy question, but
No.
it's like what they said, like with the eye, if you get somebody else's eye, would you be, or like heart, or maybe, could you see anything or feel anything that they have?
You shouldn't, there is some of that that has been expressed primarily with heart. You know, there'll be people that will say that they have a sense of that connection, not really with any other organ that I'm aware of. And I know, again, you guys have seen stories on 48 hours or 60 minutes or things where
Yeah.
parents have met, you know, the recipient of their heart, you know, and they'll want to listen to it, and they will feel a sense of connection. And the recipient many times will feel that as well. That's the only organ that I've heard that on.
Say someone is colorblind, would the
I
other
don't
person also be colorblind?
Oh. I don't know if that eye would be colorblind or not. I'd have to look up what is the genetic component of colorblindness.
I think it's the receptors that are colorblind in the brain.
Yeah, so
So you
probably
could
wouldn't
go
change a
on.
difference. It shouldn't change.
Maybe
I'd have to
in
look
one
that one
eye
up.
you would.
Yeah. So anything that's artificial is a prosthesis. Again, the most common one that you guys will see is a prosthetic leg, because we do see legs being amputated from infections, bone infections, and they get either a below the knee or above the knee amputation. So this artificial limb, you guys need to make sure, first of all, that you take really good care of it, because they're very expensive. And if something happens to it, the likelihood is they're not going to replace it through any type of insurance premiums. The second thing is that you have to watch the stump. Because if I'm putting this prosthetic and I'm putting it over, this is my stump over it, there is that risk, just like being in the bed with bed sores, that prosthesis will rub and break down skin on the stump. Some of you have possibly seen people with that, and you see that they put a big sock on their stump, and that's why they're doing that. They're trying to make sure there's a good enough fit that I don't have the rubbing or the friction on the skin. Well, let's go back to, I guess, yesterday. Do they gain weight, lose weight, or maintain weight? They lose, so they lose weight in the leg, so suddenly the stump can get a little bit smaller. Again, they're not going to recreate that stump every time that happens, so you'll see that they're taught to then take 2 socks or 3 socks or whatever it takes to create that void to keep that prosthetic to be snug in that fit. And if we can keep it from rubbing, but you need to inspect the skin when you take a prosthetic off, make sure it looks okay, report it if it doesn't, and put the prosthetic in a safe place and keep it as clean as you can. So that's the general rules of prosthetics. The second assisted device is considered visual aids, like glasses. Seems like that's pretty common sense. The safest place for your residents' glasses is on their face. Okay? The second safest place is at a bedside table. Again, if you're providing their care, you need to keep those glasses clean, you need to make sure they're in a safe place. Because again, I will tell you, if grandma gets confused and puts her glasses in the pocket of her house coat, and the house coat gets sent to the laundry services, and they locate glasses, the chances are those glasses are never coming back to the right resident. It's just not going to happen. And again, whether you're aware of it or not, Medicare doesn't pay for replacing glasses. And so you end up with an individual who then doesn't have glasses and has visual barriers to trying to care for them when it should not have happened. There has been a question on the state exam before that says, which of the following is appropriate in cleaning your residents' glasses? And the options were a dry paper towel, sanitizing solution, alcohol wipes, or a soft dry cloth. Soft dry. We just don't want to scratch the lenses. So again, common sense things that you guys will know when you see them. The next one is hearing aids. Again, very similar to glasses. The safest place for a hearing aid is in the ears. The second safest place is in the container at the bedside table. If any of you have family members with hearing aids, the biggest frustration is the batteries don't last long at all. You know, it almost makes me mad that the battery manufacturers are, you know, it's a scam. Because I'm not kidding you, they're changing batteries typically every week if they're using them on a regular basis. And so when you do remove them, most of them, if you just undo the door port to the battery, you save the battery life. And so again, they'll teach patients who can do it, residents, but if you're helping them, turn them off so that we can salvage the battery life of the hearing aid. Remember when they go to the shower to get the hearing aids out, you can't let them get wet. And again, there's usually a little brush in the box that they're contained in, and periodically just make sure that there's no wax buildup or anything that needs to be done with the hearing aid to ensure that it's clean and functional. If they're not hearing well from them, it is usually the battery. So just check that first when you're checking.
Is there a sheet, like, say you're going into a resident's room that has, like, they have a hearing aid, they have this, that?
There's a care plan that says, that lists everything. And I think,
Does
it's
Magnolia
in chapter
have
14.
that we have access to?
we can get access to it to tell you. We know most of the residents, so we can tell you the information. So we'll say, okay, you've got Miss Becker today. Miss Becker's had a stroke. She's paralyzed on the right side. She eats a pureed diet. She is able to stand and pivot into the wheelchair, but she cannot ambulate. So we give you those care plan focus points for each of the residents. But yeah, we can look at charts just for information and to see what we'd like to learn more about the resident. So yes, to answer your question.
Where are they kept?
In their chart at Magnolia, they still have the old paper charts, and then the CNAs have a flat screen computer charting mechanism, so they can look it up. It's a tap screen with just one of those like styluses, and you'll see them just tapping through to get the information. So yeah, it's a pretty neat process. They can find out. All right, the third assisted device is a wheelchair. Now wheelchairs are all types of, yes, I'm sorry, Donna.
I was gonna say, how do they have like computers like that upgraded, but they don't have the equipment they need?
Very
for-
good question.
For,
I don't know, from an administrative perspective, I think that they chose the computers because when DHEC audits you, it's much easier to quickly go through computerized documentation than it is paper documentation, and it's easier to fix some of the documentation on the computer. You're right, I mean, they've put a lot of money into these computerized flat screen systems for them to use, and there's 2 lifts for 113 residents. It doesn't make sense. It just doesn't make sense. But anyway, our wheelchairs are all types of different chairs. They can be high back, they can be traditional back, they can have footrest, they can not have footrest. Basically, if they have a wheelchair, make sure it's functional and clean. But then if they can self-propel, you want the footrest off. Because one of the things these people can develop are contractures where the legs begin to stiffen. And if I've got somebody, even if it's just a little scoot, that can do this, I want them to. I want them to be able to have that mobility to keep circulation and joint mobility. If they've had a stroke, and their stroke is on one side of their body, let's say I've had a stroke on the right side of my body, then I likely would have this leg here, but it doesn't mean I have to have this leg on a rest. So again, this is encouraged for those individuals that have only lost function on one side of their body. If they are a fall risk, we don't want them standing. We don't want them getting up for any reason. We don't want their feet dragging. And of course, we can add both of these. Doing this from this angle is not easy. All right, you guys get the idea. The other one will be on. Get it on, from this thing. And you'll have both their feet up. And again, just make sure when you get ready to go move them, that both their feet are on the rest and they're not dragging a foot underneath them or get it caught. So just make sure the wheelchair is clean, that it's functional, and that you've determined the best setup for their mobility needs. And again, just because they're in a wheelchair doesn't mean they can't be at home being provided care. The next mobility device that's listed is canes and crutches. This will be the most common type of cane that you see in long-term care now. Now remember the traditional candy cane canes, they only had about a 1.5 inch, 2 inch diameter rubber stopper on the end. So if you went to really put weight on that, that's a very small surface area to really truly have balance. So you definitely could not use it to have any kind of weight bearing. They've created this is called a quad cane, that has also been on the state test before. Quad meaning 4 tips. So now my surface area is more like a 5x7. So when I place this down, I've got much more stability so that if I need to bear a little bit of weight on that cane, it's more for balance that I can do that, so the quad cane. You will not see residents at Magnolia with crutches. It is considered too technical a device to use for them, so you won't see the crutches. But on the cane, they must be able to bear weight on both legs. And if you are in a home setting, they need to be able to bear weight on one leg with crutches. Now, most of you have probably seen the new technology, which is the scooters, which are really pretty cool. And so if my right ankle is broken, it's a scooter that you put your leg on the scooter with your knee, and then it becomes really your crutch. So it's a form of a crutch, and it's got the wheels on it, and so they have the mobility, but they're not bearing any weight on that leg. Much safer device than crutches, but again, more costly as well. The next type of device is a walker. Walkers have also come a long way in time. This is pretty much the style of a traditional original walker. And so if you saw anybody 10, 15 years ago with a walker, this is what they were doing. Right? They were picking the whole thing up and moving it. It's like, how, if they need this for balance, we've just put them at risk for that. So who remembers what they did with walkers when they figured out that was a risk? They put tennis balls on the end, didn't they? And they took the tennis balls and they cut the guts out of it and they put it on there so we could encourage them to roll it. The balls were on the front for rolling, the rubber stoppers were on the back, because if I stop and rest, they'll grip, hopefully. Okay. Well, then we got really smart. We changed it from tennis balls to wheels. So now they've got wheels on the front. And now many of them have like ski skids on the back. They're little long, like snow skis, so that I really get good surface if I really need to stop. I don't want the risk of those rolling out from under me. And then they're even getting better, because now some of them have a seat. So I can pull this seat down and I can turn around and sit down when I'm tired and take a break. And then they put these cute little fanny pack things on here now, and I can have my Kleenex and my lotion and hand sanitizer. They're crazy what they're coming up with. But again, the technology is to keep them safe and keep them independent. If you are working with a resident that is with a walker, no matter what style, the biggest risk are throw rugs or surfaces that change. So going from hardwood to carpet or something where it changes. So just monitor that if you're providing care. And again, make sure that it's in the appropriate shape, condition, and clean. The other thing is make sure it's the right height. Okay? This one is about right for me with my height, kind of a natural grip. But if I, had this, if my hands were here, this would be ridiculous, right? So all of them have a means of adjusting, much like crutches, the height of this. And again, just pushing and changing the height and making sure that when they are at the height that it needs to be, that it's at a natural stance for them. I don't want them bending over to grab, and I don't want it so high up that their arms are too flexed. Okay, so adjust those accordingly to that. All right, so that's my walkers. All right, so next with restorative care is that we want to make sure and maintain as much range of motion as we can. You want to know the abbreviation ROM. Stands for range of motion. And when we're dealing with range of motion, we are primarily talking about range of motion of the extremities. So anything that's a joint, fingers, wrists, elbows, shoulders, hips, knees, and ankles. And so if they are able to exercise on their own, if you remember back to chapter 4, we can order active range of motion where I can tell them what to do and they can pretty much follow instructions. Reach, bend, whatever that is. If they have assistive range of motion, I can tell them that they're going to need some level of assistance. So maybe you tell them again to raise their arms, and they get them so high, but they just can't get them higher, so you begin to help, with the rest of that. The third term being passive range of motion means they can't do it at all. So you are responsible for going in and providing the range of motion exercises. Now, in order for the facility to get reimbursed, they're going to want the physician to write this as a medical order. Because if I write it as a medical order, I can bill Medicare or Medicaid or their insurance. So you'll see them writing the order that would read something like this. ROMLUEQID times 10. Oh my gosh, what's all that? So ROM is range of motion. LUE, left upper extremity. QID, 4 times a day, times 10 repetitions, okay? And that's what the order would be like. So you would go in and make sure that you're doing that. The best time to do that is when you do a brief change. You're already in there working with them. Go ahead and knock it out while you're in there. So just know that they use those abbreviations, LUE, RUE, left upper, right upper, LLE, RLE, right lower, left lower. And then they also could add the assistive, active, or passive phrase in front of it as well. So on page 124, you'll see that they've got PROM. So that means it's passive range of motion. It tells you that you're going to be doing those exercises. Passive, they cannot assist in any way, so you're going to be doing them for them. So that'll be another form of an abbreviation that you might see. Now the other thing you might want to know is, well, what direction am I going? I mean, what do they want me to do? They want me to do bends? Do they want me to, what movement? And so there's movement terms. Some of them you began to learn yesterday with your matching activity. But two of the terms were abduction and adduction. So if it says PROM, that is, that's range of motion, RUE,
Right upper.
QID, 4 times a day, abduction, adduction. Now that's the movement they want, okay? So abduction is away from the body, and I told a couple of you guys yesterday, if you'll always remember, if you abduct my child, you stole it away. That's the way I remember it. So abduct is away, and adduction is to bring it back. So they would add that because that meant that that particular order was focusing on range of motion of the shoulder, because all they were wanting was the abduction, adduction. It might have that they are ordering flexion, extension. So now they may have the bend and extend where they're focusing on the elbow, or the knee, bend and extend. So flexion, extension might be a term. You might see the term dorsiflexion and plantarflexion. If you'll think of dorsal meaning fin or in a fish, dorsal flexion means to pull my foot back, dorsum. Plantarflexion means let's plant the grass, okay? So it's the gas pedal pull back movement of dorsiflexion and plantarflexion. So that may be another term that they use. They may use supination and pronation. Now on day 2, you guys learned that you can put a patient in the supine position. What is that? On their back, okay? So this is considered the anatomic position. And if I put somebody prone, they are on their belly. So this is pronate, being prone or pronation. So if the order is for supination, pronation, it's based on those positions exactly. So supinate, pronate, okay? And that's what that would mean. And again, understand these are all going to be multiple choice on the test if you have them, and so you shouldn't have any problem recognizing those. So supination and pronation. The goal behind doing range of motion exercises is to prevent contractures. Know that word. A contracture is when you get a stiffening of a limb. It is usually irreversible without surgical intervention. Now I know children, if you've ever had a child involved in the Schreiner's process, some kids are born with like a club foot, or they've got some tightening of their Achilles, things that have caused their extremity to be contracted, and they'll go in and they'll clip those things or reconstruct. That's a child's development. When they are elderly, when they are to the point of contractures, you're not going to get that back. You guys are going to get to meet my mother this morning. She's a treat. She's going to come in, but I'm going to show you her arm because it's fascinating, and I'll show you what happened when not one of my staff members, but a staff member made a mistake. She had an elbow fracture, which I told you guys about when we were talking about wound care, and she had the wound vac and the hyperbaric and all that. Ultimately, her artificial elbow got staph on the prosthetic, on the metal, and there's no way to remove that without removing the prosthetic. So they removed her artificial elbow. So she has nothing from about bone-wise, from about here And then there's no bone, no bone, no bone, till about here. So this is all soft tissue, okay? So she almost can do an exorcist movement with her arm. Well, she's gotten very good at having her arm be lifted up by doing her shoulder. And she's almost 88. There's no way they're going to put another elbow in. They've told her that. And so she has developed contracture in this hand because there's been less movement of this hand. So she literally only has pincher here, and these 3 fingers are completely contracted. And again, she's strong-willed, she's stubborn, she's German. It didn't matter what we told her about the fact you lose it, you're not getting it back. She was convinced. Well, a physical therapist convinced her that, you know what, you could get some function back if we would do the right exercises. So they had her doing this funky exercise with her arm with nothing in there but soft tissue. And when you take that soft tissue and you let it bang against each other and there's no bony structures, the joint bleeds, blood gets into that space, you get a big effusion, big old fat elbow, you have to draw the blood out. Okay, so there are instances where we are not going to do range of motion and we're not going to get back what was lost. And we're going to go see the orthopod at lunch and we're going to remind her again, you know you're not getting an elbow and know you're not going to get anything back, so quit trying to exercise it. She has an external prosthetic, so it's an artificial arm that's strapped to the outside. So it's hinged and all, so again, she can get that to move some and give her some function. And so again, fascinating stuff that goes on with our body, but you're not going to get it back once it's lost. So when we do the range of motion exercises, we are trying to prevent those residents from getting contractures, because once they have them, it's done. Again, in the elderly population particularly. All right, in this particular chapter, we are going to have 2 skills associated with this chapter. One is range of motion of one shoulder, and the other is range of motion of a knee and ankle. They are 2 separate skills. You will not draw both of them. They're too similar. Once I've seen you do it for one extremity, the assumption is you could do it for the other. But most of you will draw one of these because it is one of the short skills, and so it's drawn a lot by the computer because it's a short skill. So we're going to learn to do the abduction, adduction on the arm, the flexion, extension of the knee, and the plantar flexion, dorsiflexion of the foot for that activity. So what I'm going to do is we're going to get the skill book out. Stop the video.